After you've decided that your patient has findings consistent of a pneumonia, you want to decide, is the patient is at risk for resistant organisms? Because again, it's not just timely antibiotic treatment, but timely appropriate antibiotics treatment that's gonna make a difference. The usual resistant organisms that you have to worry about are the gram-positives, namely MRSA, methicillin-resistant Staph aureus, because all other gram-positive organisms are going to most of them are going to respond to penicillins and cephalosporins. The next group are the Pseudomonas and Acinetobacter, gram-negative organisms. These are the most risky and the most dangerous, and they need to be figured out very quickly. And then the third group are the MDROs. These can be any organism that has exhibited multi-drug resistance in the past. That means the patient has been exposed to it, or the person has shown it on previous cultures. If a person comes in and they've had an MDRO isolated from them up to 1 year in the past, then they're still at risk of having that MDRO cause pathology in them. As for who's at risk for resistant organisms, usually they are patients who have been in long enough contact, 2 or more days, with healthcare in the past 90 days. For example, they've been admitted to the hospital in the past 90 days. Or if they are patients who are in constant contact with healthcare environment, for example, skilled nursing facility residents, patients on hemodialysis, patients who receive wound care at home by a nurse, patients who receive IV medications at home, and IV chemotherapy patients. Also, patients who have been in the hospital with a current admission that's been more than 2 days are at risk for resistant organisms, and patients who have been in the hospital for more than 4 days, just more than 4 days, become at risk for MDROs because we have these running around the hospital all over the place. MDROs are any of the bacteria that you might usually encounter anywhere else that have resistance to 2 or more antibiotics. That makes them multi-drug resistant. So it could be MRSA, it could be Pseudomonas acinetobacter, or any of the other bacteria, even Streptococcus, even Strep and E. coli, that is exhibited resistance to 2 or more antibiotics in the past. So you're going to start the treatment with antibiotics that you believe are appropriate for your diagnosis. But just before you start the treatment with antibiotics, think about getting cultures. Because antibiotics will suppress, once they go into the system, they will suppress the growth of bacteria in your sputum sample. So if you get the sputum, even at the same time as giving antibiotics, you might have enough antibiotics in the system, in the sputum, to suppress the growth of bacteria, and you won't know what organisms you had when you need to, which is to decide if the patient has been responding to the treatment or not. In addition to obtaining sputum samples, there is something a little better than obtaining a sputum sample, and that's a tracheal aspirate. You don't have to have the patient intubated or trached to be able to obtain a tracheal aspirate. You can actually do this by putting a trumpet in the nose of the patient and dropping a suction catheter. This is better because you're less likely to get a spit instead of sputum that will usually have a lot of epithelial cells, and that's going to be your clue. If the sputum has a lot of WBCs, then it's considered purulent. Some astute clinicians can just look at the sputum and tell you if it's purulent, but I still stick with, are there white cell counts and white cells in there? What's even better than getting a tracheal aspirate is to get quantitative sampling from the lung itself, and that can be either a bronchoalveolar lavage, where you put the bronchoscope into the end of a bronchus and try to wash fluid into the alveolar space and suck it back through the bronchus, or you pass a protected brush, a brush that has a plug at the end, and after the brush is where it's supposed to be, you push the plug out, and then you sample the tissue there, and you retract the brush that way. These are much more sensitive, and you get your answer by counting the colony forming units, just like you do the UA, and that predicts if the person actually has a pneumonia or not.